Welcome everyone. Thank you for joining me today, and I will be talking about ventilation and perfusion matching in sick infants. Ventilation perfusion matching in 3 presentations. So today is the first presentation, and I will be focusing on physiology of VQ matching, ventilation perfusion matching, and oxygen therapy. Next presentation, I will discuss the ventilation strategies to optimize ventilation perfusion matching. And the third presentation, the future, will focus on the blood flow related challenges, so the perfusion component of ventilation perfusion matching. So what you should know at the end of this presentation. First, basic pathophysiology of hypoxemia. Second, physiology of ventilation and perfusion matching. Third, management of infant with hypoxemia, and I will be focusing on the alveolar ventilation and oxygen therapy. We know that we have certain things good for outcome. We know that prenatal steroid is good, early CPAP surfactant, breast milk, delayed cord clamping, skin to skin. At the same time, we have other things bad for outcome: infection, inflammation, oxygen therapy, hypoxemia, and mechanical ventilation. So today I will be focusing on hypoxemia and management of hypoxemia by oxygen therapy. So first, what is the definition of hypoxemia? And what's the definition of low oxygen saturation? Low oxygen saturation is variable according to your lower limit of target saturation. So if you have target saturation of 90 to 95, so below 90 is low saturation. If your target saturation 88 to 92, below 88 is low saturation. But the definition of hypoxemia is more definite. So oxygen saturation below 80% in most of the centers, which also was the limit used in the Canadian oxygen trial as a definition of hypoxemia. So anything below 80% saturation is considered hypoxemia. So what's the general mechanisms of hypoxemia? We know that hypoventilation can cause hypoxemia with high CO2. Limited diffusion through alveolo-capillary membranes can cause hypoxemia. Ventilation perfusion mismatch can cause hypoxemia. And the extreme of ventilation perfusion mismatch is right to left shunt. When you have a collapsed lung and there is no aeration but just a blood flow, that's a kind of right to left shunt. Intrapulmonary, can be intrapulmonary, it can be cardiac or extracardiac. Perfusion. So if the lung is not getting enough blood flow, that's also another issue, which is the other extreme of ventilation perfusion mismatch, which is the blood flow now the issue, not the ventilation. So I will focus today on ventilation perfusion mismatch and right to left shunt. So first, ventilation perfusion apparatus. So simply, when you inhale room air, which is about 150 millimeter mercury of oxygen and 570 of nitrogen, and about 0.3 millimeter mercury of carbon dioxide, and this air will be mixed in the dead space, and when reaching the alveoli, the partial pressure of oxygen will drop from 150 to 100, which is the alveolar partial pressure of oxygen. The nitrogen will stay almost the same, and now we have higher CO2, which is around 40 millimeter mercury, and then exhale with little bit higher oxygen than the alveoli, because it's mixed back now in the dead space, so you have a little bit higher oxygen, 112, and nitrogen is the same, 570 millimeter mercury, and now you have 28 millimeter mercury of CO2 exhaled out. And now you have the right heart, the perfusion part of the apparatus. The right heart is pumping the blood through the pulmonary artery, and now you have the blood in the alveolar capillaries, and the blood back to the left heart. And the aim of that to improve the venous partial pressure of oxygen from 50 and saturation of about 75 to be about 97 partial pressure of oxygen and saturation close to 100%. So that's a normal subject.
Do you want to ask anyone, I know there's not many people here, if they don't understand anything, to ask you, because it's a nice small audience.
Yes, sure. And I'm connecting to other sites, but I'm
okay,
recording at the same time.
that, sorry.
So I prefer if you have questions, leave it to the end, because I'm recording the presentation. So alveolar ventilation is different from minute ventilation. So if you are inhaling 150 millimeter mercury of oxygen and inhaling also about 5 ml, that's in neonate, 5 ml per kg per breath, which is around 200 ml of air in 1 minute. That's minute ventilation. Alveolar ventilation is a little bit less, which is around 150, because we now excluding the dead space. So alveolar ventilation, it is the minute ventilation minus dead space. So when we are talking about ventilation perfusion matching, we are talking about alveolar ventilation, not the minute ventilation. That's very important to consider. So alveolar ventilation about 150 ml per kg per minute. And ventilations during inspiration, because at the end of during inspiration, at the end of expiration, there is actually just a functional residual capacity, so some air remaining in the lung. At the same time, you have cardiac output, which is around 200 ml per kg per minute, anything between 150 to 350 ml per kg per minute during systole. So that's the cardiac output, which is the perfusion part of the ventilation perfusion matching. St. Boniface Hospital, may you mute your microphone, please? So cardiac output 200 ml per kg per minute, and you have alveolar ventilation 150 ml per kg per minute. The ratio between both is the ventilation perfusion matching, which is around 0.8. That's a perfect in adult, 0.8 ventilation perfusion matching. In one extreme, you may have the air moved from the bronchus and exhaled back without any exchange. In this condition, that's a dead space. So there is no any exposure of the air to the perfusion. That's extreme, and that is interactable with life. That's a dead space. So now we are inhaling 150 ml per kg partial pressure of oxygen and exhaling almost the same. There's no gas exchange. On the other hand, you have the cardiac output, or the stroke volume, which is passing through the alveolar capillaries to get oxygenated back to the left atrium. But if you have the blood moving from the right side of the heart to the left side of the heart without getting exposed to alveoli, that is the right to left shunt. So extreme right to left shunt is interactable with life, because if you have all of the blood moved from right side of the heart to the left side without getting any oxygen, like that, you cannot stay alive. So that's a pure right to left shunt. So we have two extremes: the dead space, which you have no exposure of the air, inhaled air, to the blood flow, that's the dead space, or right to left shunt, when you have right to left shunt without blood getting any exposure to the alveoli or alveolar oxygen. In this case, you just the blood passing from the right side to the left side without getting any oxygen. Now you have partial pressure of nitrogen, which is almost the same in the inhaled air, exhaled air, arterial blood, and venous blood. So in our blood we have partial pressure of nitrogen about 575. In arterial is almost the same like venous. Is this important to know or to measure? Is there any value to have nitrogen in our alveoli? Is there any value to have nitrogen in our blood? Have we ever think about that? So John West, he studied in 1960s the distribution of gases across the lung. And in this graph, you have the nitrogen, and the nitrogen actually is dynamic, moving in and out through the lung. For example, upper part of the lung is getting nitrogen from the blood, and lower part, the basal part of the lung, is getting, the blood is getting nitrogen from the alveoli, and the net balance is 0. So the nitrogen, there is dynamic movement of the nitrogen pressures between blood and lungs. And then there is another study published in Journal of Physiology 1910, almost 108 years ago. But it was very interesting study. They studied the nitrogen content of the blood, and they found an excess of nitrogen in the venous compared to arterial blood in case of you are inhaling oxygen. So we did that in actually animal subjects, and they found that when you give oxygen, pure oxygen, to the animal, the venous compartment will contain much more nitrogen than the arterial compartment. And the lung keep getting nitrogen and exhaling nitrogen. It means that the body is losing nitrogen in this case. There is no evidence that this excess is due to production of nitrogen in the ordinary process of metabolism, but it is loss of nitrogen, breakage of nitrogen from the tissues, and it is mainly in fat containing tissues, which is like bone marrow and gray matter. So these tissues losing nitrogen if you are giving pure oxygen to your baby or patient. Another article published 1930. Concentration of the amount of nitrogen gas in the tissues and its removal by breathing almost pure oxygen. So if subject inhaling pure oxygen, the nitrogen concentration decreased in the more easily removable nitrogen, which is gray matter of the brain. So the brain is losing nitrogen, which could be a sign of tissue breakdown. And then at the same time, they found that, which is very interesting, some antagonistic action might occur if you are giving pure oxygen, such as constriction of the blood vessel to keep out the oxygen. So the tissue protecting them, the cells protecting themselves from high oxygen by vasoconstriction and keeping the oxygen out of the tissues. That's a protective mechanism. It's almost the same mechanism when you have hypoxia at the tissues, so the tissues will vasodilate the blood flow to get more oxygen. So it is exactly the opposite mechanism, and it was published 1930. If you have infant inhaling pure oxygen, the functional residual capacity will be decreased gradually. So the horizontal axis is duration of oxygen breathing in hours, not days, and you have inspired oxygen partial pressure in bars. So the normal is around 1.2 bars of pressure, but if you are increasing the inhaled oxygen, the functional residual capacity will be decreased gradually over time. Hours and then days will be gradually, and then at the end will be lost. So the nitrogen is very important to maintain functional residual capacity in the lung. So clinical tips from the previous few slides. Inhaled oxygen leads to nitrogen wash out. If you are giving oxygen, for sure the nitrogen will be washed out. And nitrogen is valuable, is not actually useless in the lung or in our body. Nitrogen is important to maintain functional residual capacity. So the oxygen is important for gas exchange, but nitrogen is the gas which is maintaining the Can you mute your microphone, please? Yeah, please mute your microphone. So loss of body nitrogen through the lung in infants on high oxygen fraction may lead to tissue damage. Now ventilation perfusion mismatch and right to left shunt. In this graph you have the optimal lung, which is getting perfusion, which is getting perfusion and normal perfusion, and the lung is normal, so the blood leaving the lung now is fully saturated. Ventilation perfusion match in this case is around 0.8. Now if the ventilation decreasing, so the ratio will be decreased. Ratio between ventilation and perfusion will be gradually decreased, 0.6 to 0.4 to 0.2, and at the end you will have right left shunt. So the blood coming to the lung and leaving the lung without getting any oxygen. So we have 0 ventilation over 1 perfusion, which is 0. That's intractable with life. That you can't have someone alive with that. On the other hand, if you have the ventilation maintained but the perfusion decreasing, so you have the ratio now is 1.2, and then 1.4, and then 1.8. At the end you may have 1 over 0. So you have normal aeration, but there is no blood flow. That's exactly the same like dead space. So over 1 over 0, that's actually infinity. So the extreme, you can't have anyone alive for both extremes, but in between you have different ratios of ventilation and perfusion. So either decreased or decreasing ventilation or decreasing perfusion. So with decreasing ventilation, you may have lung collapse, pneumonia, chronic lung disease with no pulmonary hypertension or lung congestion. On the other hand, perfusion is low because of the pulmonary hypertension and vasoconstriction, massive pulmonary embolism, shock, chronic lung disease but with pulmonary hypertension. So today I will focus on ventilation perfusion mismatch and right to left shunt. So we have one lung which is lousy lung, weak, and is, in spite of maximum ventilation by mechanical ventilation, is still not getting enough oxygen. So you have partial pressure of inhaled oxygen 150 millimeter mercury, room air, and 50% venous blood getting out of the lung, 70%. So that's hypoxemia. And you have the alveolar oxygen is around 50 millimeter mercury, and alveolar CO2 is normal. So there is no issue with the ventilation, but the issue is hypoxemia. And you have a partial pressure of oxygen in the arterial blood around 40 millimeter mercury. So you have almost alveolar oxygenation reduced by 50%, because the normal alveolar oxygen is around 100 in normal subject. So you need to improve that. So roughly we increase the partial pressure of oxygen to double, from 150 to 300 millimeter mercury, which is around 42% FiO2. In this case, you may get improved saturation to 90%, and you may get improved alveolar oxygen to 70 instead of 50, and now the arterial blood instead of 40 you have now 60 millimeter mercury. So you have some improvement. And so VQ mismatch is responsive to inhaled oxygen. To improve VQ mismatch and give oxygen, the response will be positive. So there's the oxygen distribution curve to understand it more. So we have 40 millimeter mercury partial pressure of oxygen, and the saturation was around 70% in our case. And this infant or this graph showing the newborn oxygen distribution curve, which is shifted to the left compared to adult oxygen distribution curve. And you have in between the infant is growing and reaching the adult level at around 6 months of age. So we assume this infant got a lot of transfusions, and his blood volume is around 85 to 100. So you need 4 or 5 transfusions to shift to wash out all of his fetal hemoglobin to adult hemoglobin. And now we improved his oxygenation by giving oxygen. So PaO2 of around 60 or 65, and his saturation now close to 90. But if you keep increasing the oxygen, giving more oxygen, and improving his partial pressure of oxygen to 80%, the improvement in saturation will not be that much, because now after 60 millimeter mercury of partial pressure, the slope of the oxygenation curve will be more flattened. But assume that you did not transfuse your baby and still his hemoglobin is mainly fetal hemoglobin. The situation is different. So on 40%, his saturation is higher. On 40 millimeter mercury, he can be saturated around 80 or 85. So God has given him fetal hemoglobin for a purpose, and you guys may wash out his fetal hemoglobin by transfusing him, and you can reverse this mechanism and shift his oxygenation curve to the right. For sure, transfusing hemoglobin might improve the oxygen carrying capacity in anemic infant, but if you are transfusing a not very anemic infant, he actually the mechanism of oxygenation might worsen, because fetal hemoglobin is beneficial in this case. And at 60 millimeter mercury, you reached almost close to 100% saturation, and giving more oxygen will not really beneficial. You are reached already like what you need, saturation is around 95 or more. That's with the fetal hemoglobin. The same idea, if we are giving oxygen to infant with VQ mismatch, he might improve. What about if we are reducing his oxygen? It will be the same. So if you have someone on 45 FiO2, 45%, and his saturation now is 97, and now we are weaning his oxygen step by step, 2 to 5% stepwise, so the saturation will drop with the lower FiO2 and drop further, and wean more, drop further, and now you have hypoxemia. You have saturation is getting down below 85%. So when we reduce oxygen, you lose too much oxygen, and you have just a little bit movement in FiO2. So when you move his oxygen from 45 or 47 to 35%, you have significant drop in his saturation, significant drop. So he's very sensitive to oxygen reduction. That's VQ mismatch. And when you increase the oxygen back, he will improve. That's different from right left shunt. So in right left shunt, assume we have infant with totally collapsed right lung to make it easy and simple, and we have the left lung is well perfused and well ventilated. So the left lung is getting normal ventilation, and there is no any ventilation on the right lung. So the blood passing through the left lung from the venous side 75% and getting out 100%, so fully saturated. On the other hand, 75 on the right lung, and there is no any saturation because there is no ventilation here. So that's a right left shunt and the right lung, and normal ventilation perfusion in the left lung. So we have mean of saturation in the arterial blood around 87%. If you give oxygen to this infant, what will happen to his saturation? Nothing, no improvement, because the saturation on this lung, healthy lung, is already fully saturated, the blood in this area, and there is no any ventilation on the other lung. But as a compensatory mechanism, the blood vessel on this lung will constrict to move more blood to the normal lung. That's a compensatory mechanism. What about if you gave nitric oxide in this case?
Like without, yeah, but it is like we cannot hear your voice.
Can you hear me well?
Thank you so much. Thank you.
Yeah, can you hear me now?
Yeah, we are hearing you well.
Okay, good. So what's the case if you give nitric oxide to this case? Are you expecting any improvement? Maybe worsening, because you are now vasodilating the blood vessel on the other lung. The nitric oxide may be a little bit absorbed through the normal lung, and you have some escape of nitric oxide to the other lung, and you may vasodilate this lung. So nitric oxide actually might worsen right left shunt. There is no, or at least there is no any benefit. So if we apply oxygen reduction test on the infant with right to left shunt, if you have oxygen reduction test, you start with a point almost at the 90%, for example, 90% FiO2, and wean down step by step, 85, then 80, and then 70, 65, and you have the saturation. There is almost no change in saturation because you are giving extra oxygen unnecessarily, and we are weaning back the oxygen. There is no change. So pure right to left shunt is not really sensitive to oxygen, and saturation will be maintained in high 80s or low 90s, and giving more oxygen will not make any difference. That's a pure right to left shunt, which is at the extreme of VQ mismatch. So you have significant wide change in saturation, but very small change in, very wide change in inhaled oxygen, FiO2, but very small change in oxygen saturation. So we have some physiological confounders affecting VQ matching. That's a normal lung in adult, and for a long time we assume that the upper part of the lung is getting less blood because of the gravity, and the lower part of the lung is getting more blood because of the gravity, which is not 100% right. It is the level of the heart. So any blood above the level of the heart, the lung will get less blood or less pressure, and the blood in the lower part of the heart will be perfused more, and the best perfusion will be at the middle of the lung. So the upper part of the lung, you have the partial pressure of or the alveolar pressure, which is P uppercase A, will be higher than arterial pressure, which is higher than venous pressure. In this case, the blood will be stopped.
Can't hear you because your mic is. Can't hear you because your mic is. Is at the back.
So the upper part of the lung will be getting less blood, and the alveolar pressure is higher than the arterial pressure. In this case, the blood will be perfused and stop at the middle of the systolic pressure. In the middle part of the lung, the blood will be perfused during systole and stop in diastole. So the arterial pressure is higher than alveolar, but alveolar is higher than venous. So the venous flow will be low, and the blood flow will decreased or stopped at the end of systole. In the lower part of the lung, the blood flow will be continuous, systole and diastole. Here you have the arterial higher than venous, and venous higher than alveolar pressure. There is actually interesting study done in baboons, in monkeys, and to evaluate the impact of a change of position on the blood flow. So we have in this graph the blood flow and the distance to the top of the lung. So the head is up in this position, and you have the bottom part of the lung and back part of the lung is more well perfused. Please mute your microphone. Yeah, please mute your microphone.
You can turn lower volume.
Yeah, San Boniface, please mute your microphone. Okay, so the lower part of the lung will be getting more blood in upright position, including also the back of the lung. What about supine position? There is no change. Still the bottom of the lung getting more blood, and also the back of the lung. The hanging the monkey from the legs and the head is down. Still the bottom part of the lung is getting more blood, and there is no change in the blood distribution. The only change happened in prone position. For some reason which we don't actually understand why. So the distribution of blood will be almost even from back to front and also from bottom to the top of the lung. So you shift to prone position, you're getting almost even distribution of blood across the lung. That's why we are respecting that in neonates, and we are considering that prone position might be better for infants with hypoxemia compared to supine position. So you have infant on supine position, so ventilation at the front of the lung will be good, little bit worse in the back of the lung, and the perfusion is opposite. So you have perfusion more at the back of the lung. And then if you move the infant to prone position, so you have almost even distribution of blood back and front. So you have better ventilation perfusion matching with prone position. And we advise to do that in the hospital, not at home, while nursing sick babies. Effect of tachycardia on pulmonary capillary transition time. So if the blood moving across the lung, so you have the time across the capillaries, it is related to the heart rate. So in healthy subjects, he needs just the beginning of the systole to get almost the oxygen saturation full. But in sick subject, he needs longer period of exposure in the alveoli to get fully oxygenated. So if you reduce the transit time by tachycardia, then you will get much less exposure between blood and oxygen. So you will get worsening of hypoxemia. If you have infant on inotropic support and with tachycardia 200 or more, then your the oxygenation will be worsened with tachycardia. And to estimate the transition time is 60 over heart rate. So you have infant with heart rate 120, so his transition time 0.5 of second, 60 over 120. If you have his heart rate 180, so it is 0.3 of seconds. So if you have 0.3 here, he is not getting actually enough oxygenation. You need longer exposure, longer transition time. So tachycardia is affecting the transition time during oxygenation in the alveoli. What about crying? If you have infant who is sick and with hypoxemia, especially premature infants, the healthy infant, if he's crying, there is no problem. But you have sick infant agitated or crying. There's another study done evaluating the resistance and compliance in crying infant. They found that resistance increased 4 times with crying, and compliance decreased by 50%. The ratio between inspiration and expiration decreased by 1 to 5 in speed 1 to 2. So you have very long expiration, and which is worsening the functional residual capacity and evacuating the lung from air. This might lead to decreased VQ mismatch and increased right to left shunt. So you have infant who is crying for a long time. You may have in this graph, which is showing that he's requiring more oxygen before crying, and he's very sensitive to oxygen. But after crying, he will be shifted from VQ mismatch to significant right to left shunt, so very less responsive to oxygen, and his saturation cannot be improved more than 92 or 95%, even with oxygen about 60%. Now he was requiring before about 35%. After recovery, he may improve back, but you need to wean him. Even if he stayed within target saturation, you need to wean him down. So you need to adjust that. Oxygen management of VQ mismatch. Relying on pulse oximetry for maintaining oxygen saturation within 2 main target limits. So all over the world, there is actually some units which is considering low target saturation, which is almost do not exist. These like units do not exist nowadays. They are more considering higher oxygen saturation. Most of the units all over the world, 85 to 90. 85 to 89% or 91 to 95. So these two target saturations were examined in multiple oxygen trials all over the world. And in Cochrane review, they did not find any significant difference between two target saturations. In Canadian oxygen trial, they found that no difference in mortality and more incidence of ROP with the high target saturation. In the European and Australian study, they found higher mortality with the low target saturation. But overall, there is no significant difference, and I have to mention that. There is some issues with the design of all of these trials, including overlap between the two target saturations. So when we assess the pulse oximetry used in all of these trials, there was significant overlap between two target saturations, which making relying on these results is an issue. And then there is some physiologic issues with these oxygen trials, which is, in my opinion, more important to consider. They did not consider other components of oxygen delivery, like hemoglobin or blood flow. They did not consider the different mechanisms of hypoxemia cannot be treated with the same target saturation, the same like right to left shunt. They did not consider variability in end organ autoregulation between infants at the different postnatal ages. So very premature infants like 23 weeks is not the same like 27 weeks in autoregulation, and when he growing up, his autoregulation should mature. So he should be treated in a different way. They did not consider the end organ oxygen consumption. Oxygen delivery is end product of oxygen content, which is the saturation and hemoglobin, and also cardiac output. So in all of these trials, you just relied on oxygen saturation. So we did some analysis to prove the theory in our unit. So we have 18 preterm infants, all of them on FiO2 more than 40%, with acceptable cardiac output, acceptable carbon dioxide, and acceptable hemoglobin. And the autoregulation was assessed by NIRS and was acceptable on all of them. So what we did an echocardiography assessment by NIRS and assessment of pulse oximetry and oxygen reduction at the same time. And we evaluated oxygen delivery. We calculated oxygen delivery. Oxygen delivery normally between 20 to 40 millimeter oxygen per kg per minute. So what we did, we kept the cardiac output as is and the hemoglobin as measured. And we reduced in the equation saturation to be 80%. We assume that they have saturation of 80%. And we calculated oxygen delivery. The oxygen delivery stayed normal. We did different maneuvers. So we changed the cardiac output to 120, which is just the lower limit of normal. And we kept the saturation as is and hemoglobin as is. There was significant decrease in oxygen delivery. So the impact of low cardiac output on oxygen delivery is more than oxygen saturation. And the colors here, there's a reference of the colors. So acceptable oxygen delivery in green color, low oxygen delivery in pink color, and critical low oxygen delivery at the critical level of anaerobic metabolism and production of lactic acidosis will be the red color. So we changed that to hemoglobin. So we changed it in the equation hemoglobin to be 80. And then we kept cardiac output the same and saturation the same. There was more also significant change in the oxygen delivery, but the oxygen delivery changed after we reduced the cardiac output, or we calculated cardiac output as 120 ml per kg per minute. The impact was much higher than the low hemoglobin. And then we calculated the equation. We kept the saturation the same, and then we calculated the equation as low cardiac output 120, and we kept the saturation, the hemoglobin the same, but we consider saturation to be 80% and the cardiac output to 120. Then the oxygen delivery even decreased more. We kept saturation the same, but we reduced the cardiac output and the hemoglobin, and we recalculated the cardiac oxygen delivery again, and then the result was critical. So now we understand from this study that cardiac output plus hemoglobin were the most important in the equation of oxygen delivery more than saturation. And both of them were not considered in all of the oxygen trials done before. What about tissue oxygen consumption? We are using pulse oximetry, and we have 97%. So we have 97%. And if you have near-infrared spectroscopy, now we can understand the oxygen consumption, because simply the oxygen consumption is the difference between both. Is the difference between both. So the difference between both was around 32%, which is normal. Oxygen consumption between 20 to 30% is considered as normal. Fractional oxygen extraction, which is the oxygen saturation in the arterial blood minus the assumed venous saturation or tissue oxygen saturation divided by arterial oxygen saturation again, is considered as fractional oxygen extraction. It's normal between 0.15 to 0.33. So there's actually normal oxygen consumption and normal oxygen extraction. Without having near-infrared spectroscopy, we cannot understand how much oxygen consumed by the tissues. One more thing I have to mention, that if you have on pulse oximetry 97%, that's actually just a mean of the saturation. And the pulse oximetry adjusted to measure a mean within standard deviation, 6% standard deviation. So you have 97, it could be, saturation could be anything between 94 to 100%. So 97, you cannot guarantee 100% that the 97 is the real arterial oxygen saturation. It can be within 6% standard deviation, around 97. What about cerebral autoregulation? Cerebral autoregulation is it changes in the cerebral oxygenation when the arterial oxygen dropped. So we have in this graph the horizontal axis representing time in seconds, and the vertical axis representing saturation. The blue line representing oxygen saturation, and the green line or green dots representing the brain or cerebral oxygen saturation by near-infrared spectroscopy. So this is one of our infants when the saturation dropped from 95% to almost 75%. The cerebral saturation did not change significantly and stayed above acceptable level, above 65%. What does that mean? It means that with the hypoxemia, because that's definitely hypoxemia, the RBCs release nitric oxide inside the brain to vasodilate and to allow the brain to extract more oxygen, which was reflected on near-infrared spectroscopy. So that's the meaning of using near-infrared spectroscopy together with pulse oximetry to evaluate cerebral autoregulation. So that's example of infant with intact or almost intact cerebral autoregulation. There's a different infant, and there's actually an infant developed hypoxemia. He was 23 weeks, 1 week of age. His saturation dropped from 95% to almost 70%. Almost at the same time, the near-infrared spectroscopy or the cerebral saturation of the brain dropped very significantly to a critical level. This is reflecting poor autoregulation of the brain. In this case, using near-infrared spectroscopy to wean oxygen or to allow a mild drop of arterial saturation might not be helpful or safe enough. It's different from the previous case. So this infant was poor autoregulation. His arterial saturation dropped, at the same time cerebral saturation dropped, and there is not enough release of nitric oxide, or there is not enough response of the brain tissues or the brain vasculature to the released nitric oxide by RBCs. I have case scenario to clarify what we said before. A baby girl born at 26 weeks, post-menstrual age 35 weeks, with chronic lung disease. FiO2, 90% to 100% to maintain saturation between 91 to 95%. for almost last 10 days. She stayed or he stayed on 100% oxygen for almost 10 days. Complete wash out of the nitrogen, that's one issue, and exposure of the lung to 100% oxygen for more than 10 days. On high frequency jet ventilation, mean air pressure of 14, partial pressure of oxygen in the arterial blood was 40 millimeter mercury, and partial pressure of carbon dioxide was 40 to 58. And this is actually the X-ray, which showing significant coronary lung changes. We may rely on X-ray to evaluate the inflation of the lung, but it is meaningless to reflect the functional part of the lung, the ventilation part, because you may have inflated part but not really functioning well in the oxygen exchange. And this is echo. So they assume that there was pulmonary hypertension and keep treating the baby as pulmonary hypertension with acceptable saturation, target saturation between 90 to 95%. There's fourth chamber of the heart, and the left side and right side. So you have the right side more dilated compared to the left side, and more dilated even than usual. This baby had PDA which was closed, and the left side stays for some time dilated after closure of the PDA. So there is no pulmonary hypertension. The apex made by the left side, and the right side is not dilated at all. So the assumption was wrong. And then we applied oxygen reduction test at the bedside, and we applied that using pulse oximetry and using at the same time near-infrared spectroscopy. So the oxygen we started at almost 2 hours, and keep doing that over 2 hours, and I was able to decrease the oxygen from 100% almost to about 60% in 2 hours after being on 100% oxygen for almost 2 weeks. So the FiO2, I just selected few points to compare. FiO2 is 85%, saturation is 93. Cerebral oxygenation was 88%. What does that mean? The brain was exposed to hyperoxia. Anything above 85% is considered hyperoxia. Brain is getting more oxygen than needed. And then calculated oxygen fraction was low. Hyperoxia can cause vasoconstriction and decrease oxygen extraction of the brain, which is dangerous. And then we started to wean oxygen further. The saturation did not change significantly with decreasing the FiO2. What does that mean? Significant right to left shunt. So significant change in oxygen fraction, inhaled oxygen fraction, but without significant change in saturation. Significant right to left shunt. At the same time, the brain oxygen actually improved from the hyperoxia side to acceptable level with improvement of fractional oxygen extraction. So the brain started to extract more oxygen because we assume that the oxygen goes in vasoconstriction and reducing the extraction of the brain. At this point, we have the FiO2 reduced to 55, but the saturation dropped to 75%. The brain saturation stayed okay. What does that mean? Intact autoregulation of the brain. So the brain autoregulation was intact. So we have many clinical tips from this test. Significant right to left shunt, not pulmonary hypertension was the main reason. And then the brain oxygen extraction improved with weaning oxygen, and intact autoregulation of the brain. So that's oxygen reduction test, and we applied that on a software, and this software is present online. So we have the inhaled oxygen fraction. It's like kappa, but it is the same number if we used FiO2 as percent. So 55 inhaled oxygen by kappa is almost the same, like 55% inhaled oxygen if you are at the sea level. As the saturation did not decrease significantly, and calculated by the software, calculated right to left shunt was around 25%. So this curve here, 25% of the blood shunted without getting any oxygen, 25% right to left shunt, and VQ mismatch was or VQ ratio was 0.21, worsening from normal, which is 0.8. So we have significant drop of inhaled oxygen with little bit of change in the saturation, which is typical example of right-left shunt. Few days after, we started steroids and we started weaning by integrated oximetry and near-infrared spectroscopy to be sure the brain saturation was maintained with the normal. And now you have the FiO2 between 35% to 28%. That's oxygen reduction test. You have the right-left shunt improved to 10% only, and VQ ratio improved to 0.25. So we have with a small change in the saturation, little bit significant change in the significant change in the saturation with little bit change in the inhaled FiO2. Lessons from this case: the impact of right to left shunt on hypoxemia was significant, not the pulmonary hypertension. Relying on certain oxygen target saturation might not be physiologic in all cases with chronic lung diseases. Pulse oximetry is insufficient in assessment of hyperoxia. You need to combine that to PaO2, partial pressure of oxygen, but the issue, we don't have applicable continuous monitoring of partial pressure of oxygen in preterm infants. Hemodynamics effect of hyperoxia, that's very significant. If you expose infant to high oxygen for a long time, you will get almost all of the organ of the body will be affected, including the lung. Retinal damage, you have erythrocyte hemolysis, myocardial damage, endocrine effect, adrenal, gonadal, and thyroid, renal damage, hepatic damage, everything will be damaged in the body. Remember that you are giving oxygen with more oxygen-free radicals. At the same time, even if the blood not getting enough oxygen from the lung, you have wash out of the nitrogen, because the body will keep excreting the nitrogen through the lung, and the nitrogen content of the body or these organs will be much less. Hyperoxia reduces oxygen consumption in children with pulmonary hypertension, and we have mentioned that with hyperoxia, with the assumed pulmonary hypertension and keeping your infant on higher target saturation, you will get much less oxygen consumption in all of the body organs, especially or particularly the brain tissues. Long time ago, we were considering 100% oxygen for resuscitation, including infant with HIE. And now we understand that resuscitation with room air is much more beneficial, and resuscitation with 100% oxygen is really harmful. Harmful for the brain, cerebral vasoconstriction, brain inflammation, and worsening of HIE. Worsening of pulmonary vascular reactivity, and decreased relaxation response to nitric oxide, myocardial damage, acute renal damage. All of that just when you consider resuscitation with 100% oxygen rather than room air. And even in the future, this infant will be at higher risk of childhood leukemia. So with the significant VQ mismatch, we have 0.3 VQ mismatch and right left chance 20%. Again, I just repeat that again. You have now significant drop of saturation with little bit of change in the oxygen fraction of oxygen. So VQ mismatch is really responsive to inhaled oxygen changes. To conclude for our presentation, infant with mild to moderate VQ mismatch is responsive to oxygen therapy and sensitive to oxygen fluctuation. Nitrogen washout due to inhaled oxygen or high oxygen fraction is dangerous on both lungs and other organs. Infant with severe VQ mismatch and right to left shunt is poorly responsive to higher oxygen fraction. So you have severe VQ mismatch, and then you have high right to left fraction or higher right to left shunt fraction, then the response to oxygen will not be optimal. And you have to consider that when you start weaning the infant. Don't consider giving more oxygen will improve his oxygenation. Pulse oximetry is insufficient in assessment of hyperoxia and oxygen delivery. Integrating pulse oximetry and near-infrared spectroscopy is helpful in assessment of autoregulation and the avoidance of hyperoxia, and we have proven that in our case scenario. At the same time, it's helpful in weaning from high oxygen fractions. Next presentation, I'll be talking about mechanical ventilation strategies to optimize ventilation perfusion matching, including usefulness of ventilation waveforms. Thank you very much. Now I'm ready for your questions.